Welcome to our Tuesday Stroke Survivor Support Group meeting. I'm Ralph Preston. I run Stroke Buddies and I organize these meetings, and we have them every Tuesday. We also put them on YouTube, which is where you may be watching them if you can't get to them. And for the third time, we have Dr. Hetzler. We're really blessed to have found him because I find his presentations very helpful. Full of good information and easy to understand. So I know he's got a lot to cover today, so without any further ado, I'm going to turn it over to Dr. Hetzler, who's going to present on stroke overview.
Well, thank you, Ralph. I'm going to share my screen now, and here we go. There. Can you all see that?
Yes, sir.
All right, then. It'll be an overview of the stroke, and of course, the stroke occurs in your brain, so we're going to talk about the brain. These are the topics: brain structure, spinal cord structure, neuron structure, stroke type, impact of stroke location, left neglect after stroke, Gerstmann syndrome, post-stroke fatigue, and stroke recovery. There's a lot of material to cover, so I will do my best to keep it under 10 hours. So here we go. In the United States each year, more than 795,000 people have a new or recurrent stroke. According to the National Stroke Association, around 2 in every 3 stroke survivors will have some form of disability. Stroke is the leading cause of disability among American adults. Post-stroke depression is the most prevalent psychiatric disorder after stroke. It affects nearly 1/3 of the survivors during the first 5 years after disease onset. This is one reason stroke survivors are often prescribed an antidepressant initially. It's effective, in addition to relieving depression, in helping stroke recovery during the first year. I know that I was prescribed Lexapro for the first year of my stroke. Stroke sufferers are also 2 to 3 times more likely to develop chronic pain than non-stroke sufferers. Depressed mood, social isolation, poor subjective well-being, and mental distress contribute to increased motor impairment, disability, and risk of future stroke. So we are going to talk about the nervous system now. And here's a diagram on the left-hand side. There are names. I realize these are probably meaningless names for the most part now, but they're color-coded with the diagram on the right, which is a mid-sagittal section that is cut down the middle of the brain, and you're looking at the right hemisphere. The blue part up here is the cerebral cortex. This is all part of the what's called the forebrain, and that includes the cortex, basal ganglia, limbic system. Then the sort of yellowish gold is the diencephalon, which contains 2 main structures, the thalamus and the hypothalamus. And then we get down into the brainstem. This purple part is called the midbrain, and then below that is the pons, and the back of the pons is the cerebellum, and then we have the medulla, and below that is the spinal cord. I hope you remember this because there will be a test at the end. Okay, this is the outside of the brain. You're looking at the brain from the left-hand side. So you're looking at the cerebral cortex. Cortex means bark. And like the bark of a tree, the cerebral cortex is on the outside of the brain. In that regard, how can you tell that a tree is a dogwood tree? By its bark. My wife doesn't like that joke, but I like it, so I tell it anyway. Now, this is a section through the brain, and there are several things I want to point out here. First, you can tell the difference between the gray matter and the white matter. The gray matter here looks more gray than the white matter, which looks white. The gray matter is made up mainly of cell bodies, neuronal bodies, and I'll talk about the structure of a neuron a little later on. The white matter consists of axon pathways. And again, I know I haven't talked about what an axon is, but I'll get there. And axons are generally covered with a myelin sheath. And a main component of myelin is cholesterol, which looks white. Also, you can see here that a groove in the brain is called a sulcus, while a bump is called a gyrus. Now, a larger groove is called a fissure. This is a little terminology we will come to a little later. Also, the upper side of the brain is the dorsal side. The underside is the ventral side. And please ask any questions if you have any. I'll do my best to answer them. Now, I should point out, you'll see it in another slide also, but this white matter here interconnecting the two hemispheres, is called the corpus callosum, that interconnects the two sides of the brain so they can coordinate their activities. If this were severed, the two halves of the brain would think independently. And they would move independently. In fact, there was one clinical case of a man with a severed corpus callosum, and he was trying to hit his wife with one hand and stop that hand with the other hand. So did he really want to hurt her? Yes and no. Depending on which side of the brain you're talking about.
Did he have two separate consciousnesses?
Yes.
Wow.
He had two separate consciousnesses. And there's another case where a man was trying to read a book, holding it up with his right hand, but trying to put it down with his left hand. Because the left hand was controlled by the right hemisphere, and the right hemisphere can't read. So yes, the two hemispheres can think independently. Now that only happens again if the corpus callosum is severed, which can happen as a result of a war injury or extra credit for an introductory psychology class or something like that. Okay, here you're looking at the left side of the brain. There are four lobes. There's a frontal lobe here. That's at the front of the brain. The very back of the frontal lobe is your primary motor cortex. That's the part of the brain that becomes active when you move. Behind that is the parietal lobe. That's for the somatosensory system. That's where you feel pressure, pain, cold, and warm. One of that right here is where your body is mapped out here. This is where you feel the different sensations in different parts of the cortex. Down here is the temporal lobe. That's involved in hearing. And at the back of the brain is the occipital lobe. This is your primary visual cortex at the very back of the brain. When that's active, you see something. So why does a boxer see stars when he's hit on the chin? That's because this primary visual cortex crashes up against the inside of the skull, and that sets up activity in neurons there, and the boxer sees stars. Now, in terms of the general organization of the nervous system, many axon pathways, beginning or ending in the cerebral cortex, are crossed. That is, areas in the right cortex receive sensory information and control motor movement on the left side of the body. This is called contralateral control. For visual information, the left visual field in each eye goes to the right visual cortex, while the right half of the visual field of each eye goes to the left occipital lobe and the left visual cortex. If you're looking straight ahead and centered on something, everything to the left of your field of vision is your left visual field. Everything to the right is your right visual field. Now that's illustrated here. This is looking down on top of the brain. And on the left here, it says left brain, that's really the left hemisphere. And down here, it says right brain, and that's the right hemisphere. With the two eyes looking forward. And if they're centered here, everything to the right is the right visual field, and then the left visual field. Looks like someone's opened a bag of potato chips or something. I guess I'm making you hungry. Here we're looking at the left lobe, the left cortex, and all the language centers for expressive language are here in the left hemisphere. So here, in the frontal lobe, is Broca's area. When that area is damaged, that's when you have Broca's aphasia. That's what people are most familiar with. That's where you have difficulty talking. Down here in the temporal lobe is Wernicke's area. That's where you have difficulty understanding speech when this is damaged. Interconnecting Broca's area and Wernicke's area is a band of axons called the arcuate fasciculus. And it's through that pathway that you talk to yourself. Now here is the angular gyrus. And that's sort of between the occipital lobe, which controls vision here, and the temporal lobe, which controls hearing. And the angular gyrus is sort of an interface between vision and hearing. It's very important in linguistic abilities. For example, when you read, you see something visual, but to understand it, it has to be converted into an auditory form. And that change occurs in the angular gyrus. The angular gyrus takes visual information and turns it to an auditory form where Wernicke's area can understand it. So let's say you want to write something. You have to imagine a visual image, and that gets converted. Excuse me, if you want to write something, you have an auditory thing that has to be converted to a visual thing so you can write it. And that auditory to visual, again, occurs through the angular gyrus. Because although you think of it in auditory form, if you're going to write it, it has to be converted into a visual form. You can write out the letters. And that auditory to visual transformation again occurs in the angular gyrus. What that means is if you have a stroke in the angular gyrus, you will end up with alexia with agraphia, inability to read and inability to write. Any questions? Okay. Now this is a nice simplistic view of how the brain divides its work. Looking down on top of the brain, so we have the left hemisphere here, the right hemisphere here. The left hemisphere controls the right hand. Mathematical abilities are here in the left hemisphere. Language, science, logic, writing, all left hemisphere abilities. Right hemisphere controls the left hand. Your music appreciation is here. Dance, art appreciation, fantasy, sculpture. Those are right hemisphere. Now we get to the prefrontal cortex. That's the front of the frontal lobe. Well, they're really going through those potato chips there. It's critical for making decisions, planning actions, evaluating optional strategies. This area is involved in your personality. If you have a stroke in the prefrontal cortex, your personality can change, sometimes drastically. It's the last part of the brain to mature, that is, fully myelinate. I know I haven't talked about myelination. I'm going to get there, and you'll understand it a bit, but that's when your prefrontal cortex, again at the front of the brain, is fully myelinated, which occurs in your late 20s. That's when your personality is mature. You can make good decisions.
Wow.
Now, this prefrontal cortex, unfortunately, was the part of the brain that was involved in what was called a frontal lobotomy. That's illustrated here. And basically, that part of the brain was severed from the rest of the brain. This procedure was popularized in the 1940s and 1950s. Even one of the Kennedy daughters had a frontal lobotomy. What did the alcoholic schizophrenic say to his doctor? I don't know if I'd rather have a frontal lobotomy or a bottle in front of me. Moving along, please. Yeah. Here's the spinal cord.
Some dyslexia thrown in there too.
Yeah. I used to be dyslexic, but I'm KO now. Okay, here's the spinal cord. That's about the size of your little finger. And you see nerves coming in and going out of the spinal cord.
Wow.
A cross section of your spinal cord looks like this. This is the dorsal side. That's toward your backbone. It's the ventral side. That's toward your stomach. Now you can see sensory neurons send information over the dorsal root, while motor neurons, these are the ones that control your body, leave via the ventral root. They come together in a spinal nerve. We have outgoing information to the muscle and incoming information from the skin surface. Okay? Now, at the very top of the spinal cord, we have the brain stem. It includes several structures, the medulla and the pons. Behind those are the cerebellum. The midbrain is above the pons, is the top of the brain stem. I will show you where these are. If you look down at the bottom, keep losing my little arrow here. There we go. Here's the spinal cord. Above that is the medulla. And then here's the pons and the midbrain. That's the brainstem. Behind that is the cerebellum. You with me so far? Okay. Now the brainstem will start at the bottom talking about the medulla that controls the vital reflexes of the body. It regulates your heart rate, your digestion, respiration, blood pressure, coughing, and vomiting. Drug overdoses often cause death from depression of the breathing center in the medulla. That's what happened to Jimi Hendrix, Janis Joplin, and Prince, to name a few. So a stroke in the medulla can easily be fatal. The pons is just above, a little higher than the medulla, that contains sleep centers. Sleep is an active process. It occurs when centers in the pons become active. The cerebellum is that structure that looks sort of like a little head of cauliflower behind the pons. It's involved in movement and balance. It integrates sensory and motor information. It controls rapid movements and hand-eye coordination. Ralph, you were commenting that you were juggling 5 balls. Well, that would involve your cerebellum. You would need that. Or, for example, if you're playing tennis, you have to coordinate the swing of the tennis racket, that'd be the motor output, with your visual information of the vision of the tennis ball coming towards you. That coordination of hand and eye is controlled by the cerebellum. Now, if you've ever wondered why you don't drive well when you're drunk, I'm sure you've wondered that, sir, Ralph.
Yeah, I have.
That's because alcohol depresses those timing circuits in the cerebellum. Makes it very difficult to drive. So don't drive while you're drunk. Okay?
Okay.
Good. Now, this is a mid-sagittal section of the brain. Here's the cerebellum back here that I was just talking about. Here's the medulla, the pons, and the midbrain. Now there's this striped area. Of course, in your brain it's not striped, but here it is. This is the brainstem reticular formation. The main function of the reticular formation is to keep the brain awake. When you go to sleep, the reticular formation is turned off. When you wake, it's turned on. The main cause of coma is damage to the reticular formation. So you could easily go into a coma if you have a stroke in the reticular formation. It's not the only cause of coma. Massive destruction of the cerebral cortex will also produce a coma. That's what happened in the Terry Schiavo case from several years ago. But the main cause of coma, again, is damage to the reticular formation, which can occur in the case of a stroke there. We now move up to the diencephalon. That consists of 2 main structures, the thalamus and the hypothalamus. Where might the hypothalamus be located with reference to the thalamus? Yes, Ralph.
Above it.
Well, you're exactly wrong.
Perfect.
Hypo means under.
You're right.
Hypothalamus, yes, I know I'm right. The hypothalamus is under the thalamus. The song Under the Boardwalk could have been Hypo Boardwalk, because hypo means under. And the thalamus receives sensory and motor information and passes it on to the cerebral cortex. It also allows for selective attention. That occurs in the thalamus. Now, I think the last time I spoke, there was a woman who said she had a stroke in her thalamus. Now this shows the thalamus. You have a thalamus inside each hemisphere. It's egg-shaped. These arrows show how it sends information on to the cerebral cortex. You have two thalami, one in each cortex, the one in each hemisphere. The hypothalamus receives information about the internal environment and coordinates with the limbic system to maintain homeostasis. It regulates body temperature, balance, salt water balance, hunger, thirst, energy, metabolism, reproductive behaviors, and emotional responses. So the telencephalon is an all-encompassing term for the cerebral cortex plus the things that are under that, and things under that are called subcortical. So if you had a subcortical stroke, it would be in the telencephalon under the cortex. The main structures under the cortex are the basal ganglia and the limbic system. The basal ganglia are involved in motor control, or what we call slow movement. The limbic system is a little more complicated. I'll get to that later. This shows structures in the basal ganglia. There are really three structures: the caudate, putamen, and globus pallidus. The caudate and putamen are collectively called the striatum. Now, this is a mid-sagittal view of a rat brain. Here you have the front of the brain. You have the caudate and putamen, which again are collectively called the striatum. And then here you have a structure called the substantia nigra, which is part of the midbrain. I'm showing you this because there is an axon pathway that goes from the substantia nigra to the striatum. It's called the nigrostriatal dopamine pathway. It releases dopamine in the striatum of the basal ganglia. This pathway normally degenerates over time, and when 80% of the fibers are gone, that's when you get Parkinson's disease. Now, the fibers here normally degenerate, but things sometimes happen during life to accelerate that progression. And that's why certain people are more likely to get Parkinson's disease. But there are certain chemicals that can cause this as well. Now we get to the limbic system. The whole group of structures. Limbus means circle, and they form sort of a circular interconnection in each hemisphere. It's first described by Papes. It looks like it would be pronounced Papez, but it's actually Papes. And these structures are involved in emotional behavior, memory, and motivation. I will talk about emotional behavior and memory. Now, this shows the structures that I'll be talking about. Much of the temporal lobe has been removed here, but I'm showing to show you two structures in the temporal lobe. This is at the front. This is called the amygdala, and this is the hippocampus. Another area is the septal area, located here. Now we'll talk about the amygdala versus the septal area. Removal of the amygdala causes taming and docility. This is based on laboratory research with animals, but you also see this in human conditions in which there's been a stroke or viral infection of the brain. Removal of the septal area causes the septal rage syndrome. If the septal area is destroyed in a rat, It will indiscriminately attack anything that moves, including the experimenter. I once saw a rat with the septal area removed chase a computer programmer up on a stool. This is a big burly guy that weighed about 250 pounds, I would guess. He was standing on top of the stool saying, "Get that rat away from me." The rat was on the floor, standing up on its hind legs, trying to jump up and bite the guy. So stay away from animals, or humans for that matter, the septal rage syndrome. Then we have the hippocampus. It's associated with the establishment of new conscious memories, not unconscious ones, but conscious ones. Also spatial memories, that is remembering that you've seen a place before. There are what are called place cells, the hippocampus. They become active when you enter a familiar environment. Now, who is this man and why am I showing you his picture? This is the single most famous patient in all of neuroscience. He's known by his initials, HM. On the left-hand side, we have a ventral or underside view of HM's brain. And here we have a coronal section of his brain. On the right, we have a normal brain. Now you'll notice there's an area that is removed from both hemispheres of HM's brain. This caused amnesia. His severe memory impairment lasted from 1953 until his death in December of 2008. It was the result of the removal of both hippocampi to control seizures. And it turned out, as a result of that, he could no longer learn new words, songs, or faces. That is, he could not learn new conscious memories. He did learn some new motor skills, but he had no memory of having learned them. That is a neuron, actually two neurons, and a microelectrode. These are neurons. Your brain has about 100 billion neurons. That's B, billion. That's a lot. Neurons have three parts: a cell body or soma that contains the nucleus of the neuron, dendrites, these are projections from the soma that receive information from other neurons, and an axon that extends from the soma and conducts information to other neurons or glands. And the axon, as I mentioned before, is covered with myelin, actually segments of myelin. Here's a picture of a neuron. Here's the cell body and dendrites. And here's an axon with segments of myelin with little gaps between the segments. The gap is called a node of Ranvier. It's named after its discoverer, which is Ranvier, not node. You could think of an axon as a 10-foot long hot dog surrounded by hot dog buns all the way along, with each hot dog bun representing a segment of myelin. The function of the myelin is to allow the message that the neuron is sending to go down the axon faster. It goes down about 20 times faster because of the myelin. Some diseases like multiple sclerosis attack the myelin and therefore disrupt processing in the nervous system because the messages do not go down the axon the way they should. Now you'll notice that the axon ends with these terminal buttons. It's through these endings that one neuron sends information to another neuron. That's an artist's conception of an axon ending. This ending contains a chemical substance called a neurotransmitter. And these are little spheres, or what are called synaptic vesicles, that release the neurotransmitter into the synaptic cleft, and then the neurotransmitter interacts with receptors on the postsynaptic membrane. So you have a presynaptic membrane at a synapse, postsynaptic membrane, and a synaptic cleft in between. This shows a single neuron with axons approaching it, and the axons sending out axon extensions, each ending with a synaptic knob. So here you've got 1, 2, 3, 4, 5 axons with many synapses on this receiving axon. A single neuron may have 50,000 or so synapses, and those determine the function of this neuron because they determine whether it will be active or silent. This whole network, of course, is disrupted by a stroke. You're losing neurons and the connections that make them function the way they should. In a stroke, you have reductions in blood flow to the brain of sufficient duration and extent, resulting in damage to neuronal networks and the impairment of sensation, movement, or cognition. There are two main types: ischemic versus hemorrhagic. Ischemic or obstructive stroke is the most common form, accounting for about 87% of strokes.
It's a little high, but yeah, it's good.
No, I'm not high. That's okay.
I don't have the mute all button.
That's okay. A hemorrhagic stroke accounts for about 13% of strokes. This arises from a leaking or ruptured blood vessel. This shows the difference. In an obstructive stroke, you have blockage. Well, in a hemorrhagic stroke, you have a blood vessel that leaks or bursts. The penumbra. This is the area of tissue that borders the stroke. It's the area that experiences reduced blood flow. Neurons in the penumbra are damaged by the stroke, but they can recover during reperfusion. So this shows in an ischemic stroke, the stroke core, and this other area, the penumbra. Following restoration of blood flow, you still have an ischemic core that is destroyed, but neurons in the penumbra can function. By the way, during a hemorrhagic stroke, there is no penumbra. You just have the core. What causes a stroke? A common cause of stroke is atherosclerosis, or what's called hardening of the arteries. This involves plaque made of fat, cholesterol, calcium, and other things that builds up in the arteries, leaving less space for blood flow. So a blood clot may lodge there. Hemorrhagic strokes often result from uncontrolled high blood pressure that causes a weakened artery to burst. That's what happened with me. Here you have atherosclerosis. Pleasant, isn't it? Is that your personal or professional opinion? Location, location, location. Just like real estate, location, location, location is important in a stroke. Exactly how a stroke affects someone depends on what side of the brain it occurs and the amount of damage. So some people may experience a temporary arm or leg weakness, while others may lose the ability to speak or walk. A stroke in the left hemisphere is more likely to disturb language production and or comprehension, which of course reduces the ability to communicate. So aphasia from stroke most often develops after left hemisphere strokes. When the right hemisphere is affected, the intuitive thinking, reasoning, and problem-solving abilities, as well as perception, judgment, and spatial functions could be impaired. The right hemisphere strokes can make it difficult to locate objects, walk up or down stairs, or get dressed. I had a right hemisphere stroke, and my wife is impressed that I can dress myself in the morning. But she was impressed that I could dress myself in the morning before my stroke as well. So this shows if the right side of the brain is damaged, the left side of the body is affected. What about left neglect after stroke? The parietal lobe, which you will recur is right behind the frontal lobe on both sides of the brain, plays a strong role in spatial awareness. And the right side parietal lobe plays an even bigger role in attentional processes. So we rely on our right parietal lobe to help us notice the environment on the left side of our body. Therefore, a right side parietal lobe stroke is likely to result in what's called left side neglect. The biggest symptom of left neglect after stroke is difficulty noticing things on the left side of the body and environment.
Yep.
This means you may eat from only the right side of the plate. May read and write from only the right side of the page, and may ignore caregivers unintentionally when approached on the left side. My stroke was subcortical in the right thalamus, but that area is right below the right parietal lobe. And I had some left neglect after my stroke initially. So, for example, my therapist later told me that when we were all seated around a table, I would tend to just pay attention to the therapists and doctors on the right-hand side. The therapist on the left-hand side would be waving their arms and say, "Bruce, look over here," and I would ignore them. Also, when I was in bed in the hospital, a physician came in and lifted my left arm and said, "Whose arm is that?" And I said, "Matthew's," Matthew being my son. Well, it wasn't his arm, it was mine. Now, I don't remember that happening. My wife told me that. Now, this shows what would happen during left neglect. That is, eating only from the right side of a plate, not the left. Were any of you ever asked to draw a clock? That's something that I had to do during an 8-hour neuropsychological test that I had to take before I could return to teaching at Lawrence University. And no, this is not the clock that I drew. I drew one perfectly. But someone with left neglect would draw a clock like this. Now, the upper slide here, or upper figure, shows the left hemisphere. This is the primary somatosensory cortex, or what is called S1. And down here is secondary somatosensory cortex, or what's called S2. I mention that because damage in the left hemisphere, parietal lobe, outside of S1 and S2, that is somewhere in here, causes Gerstmann syndrome. The main symptom of Gerstmann syndrome is an inability to distinguish between your fingers, or what is called finger agnosia. Agnosia is a term that was introduced into medicine in 1891 by Sigmund Freud. Freud was an excellent neurologist before he became a psychiatrist. So people with Gerstmann syndrome have difficulty naming a finger. That if someone touches their finger, or they may give the wrong name. Like if they touch their index finger, they may say their thumb. They have difficulty holding up, let's say, their index finger if asked to do so, or point to a finger on a chart. Or if someone gives them the finger and they go to return it, they might hold up their thumb. Well, that's same to you, bud. They also have difficulty writing and drawing and difficulty with mathematics. It's interesting that there's problems with your fingers and with mathematics. You probably all learned to count initially on your fingers. Although, Ralph, I think you said you learned to count on your toes.
Well, after I was doing complex math, I needed to add the toes in.
Okay. We'll move on to post-stroke fatigue. It's something that's common after stroke. And fatigue from stroke differs from normal tiredness. While some people with fatigue feel better after a nap, stroke survivors with fatigue might not feel energized even after a full night's rest. And post-stroke fatigue can affect anyone, young or old, active or sedentary, male or female. The exact cause of post-stroke fatigue varies from person to person. One example is that the body uses energy differently after a stroke. For example, if a leg has become difficult to move, it will take more energy to move around. If you struggle with post-stroke pain, that requires a lot of energy to cope with. This can deplete your energy, leading to post-stroke fatigue. Fatigue could also result from emotional factors like grief, depression, or something else. But the size of a stroke is not related to the severity of post-stroke fatigue. Someone who survived a massive stroke may have little fatigue, while with a mild stroke, you may feel tired all the time. How do you manage post-stroke fatigue? Well, you can talk to your doctor, check medications for side effects, conserve your energy. Keep an energy journal, improve your stamina, eat well, sleep. Sleep is important for any stage of stroke. It's especially important right after your stroke. Now, this was a problem for me because I was placed in the intensive care unit of a hospital for 2 weeks after my stroke. And unfortunately, the intensive care unit was right next to the helicopter landing pad. So in the middle of the night, the helicopter would either take off or land and wake me up when I'm supposed to be sleeping to help my stroke recovery. Well, needless to say, I got relatively little sleep then. What about stroke recovery? Well, some spontaneous recovery does occur after a stroke, but it doesn't continue forever. Spontaneous motor recovery only occurs during the first 6 months or so. Afterwards, you need rehabilitation or post-stroke therapy to make further progress. In fact, there's a remarkable capacity of the adult brain to undergo plasticity that promotes recovery from stroke damage. And there are parallels between plasticity in the developing nervous system and that takes place in the adult brain after stroke. Which brings us to neuroplasticity, which is the brain's ability to change or learn by forming new connections throughout life. And it's this neuroplasticity that allows neurons in the brain to compensate for injury. Now here I wrote stroke recovery with a question mark. And that's because reemergent post-stroke behavior is unlikely to be identical to pre-stroke behavior because you've lost neurons that do very specific functions. Other neurons can compensate, but probably not exactly duplicate.
Hey, doctor,
Yes,
will you define reemergent post-stroke? What do you mean by that?
post-stroke means after stroke.
No, reemergent
Oh,
post-stroke.
reemergent. That means behaviors that emerge after your stroke. Like right after your stroke, immediately after, you may not be able to walk or do anything. But later, your ability to walk will re-emerge. And that walking after your stroke will probably not look identical to what it looked like before.
Got it. Thank you.
Sure. Also, commonly used human behavioral assessment protocols can rarely determine the extent to which any improved performance reflects true recovery, behavioral compensation, or a combination of both. So you probably had a lot of assessments done during physical or occupational therapy. During occupational therapy, one of the tests they gave me that I always hated was the one with a little plastic board with like 9 holes in it and 9 white pegs. You had to use your affected hand to pick up and put in the holes. They can measure how long it takes you to do it, and you might improve. In fact, I got 2 minutes faster. But they can't tell if that's because I'm recovering what I lost or just compensation. Now, how do you recover? Well, the motor and sensory cortices, which I showed you in an earlier slide, are loosely organized into what are called somatotopic maps that exhibit a lot of use-dependent plasticity, as they can be modified by experience. The motor maps reflect the ability of specific neurons in the motor cortex to control specific muscles. The sensory maps represent the pairing of sensory input from the body to specific sensory neurons in the brain. Again, these maps are located here. Your primary motor cortex has got a map of your body here. It's called a motor homunculus, and I'll show you this in a minute. Your somatosensory cortex is a sensory homunculus. This shows the motor homunculus. Your body is mapped out here, and the size of this map, or the homunculus, shows how much of your cortex is devoted to each body part. You've got a lot devoted to your hands, your feet, and especially your face and your mouth. You have enormous control over your mouth and your hands. So that's your motor homunculus. That's what you look like to your brain. Of course, I think I look a lot better than that.
You do.
Well, thank you. Well, so do you. So what factors contribute to recovery? Well, first, there's a surprising amount of redundant connectivity, a lot of redundancy. Second, new connections between neurons can form in the brain. Now, I mentioned before, in general, body parts are controlled by neurons in the cerebral cortex on the opposite side of the body. That's that contralateral control. There are ipsilateral pathways in which, for example, the right hemisphere controls the right side of the body. And you can make increased usage of these ipsilateral pathways. And functional magnetic resonance imaging, fMRIs, show that this is very important in stroke recovery. So one factor in stroke recovery is the use of brain regions in the intact hemisphere. So if you had your stroke on the right side of the brain, the ability to use the left hemisphere. But recovery of language in patients with aphasia depends on organization or reorganization in the left hemisphere, because the right hemisphere is mute. The right hemisphere cannot talk, and there's no way you can get the right hemisphere to talk. So your ability to recover from Broca's or Wernicke's or whatever aphasia depends on the ability to use the intact neurons in that left hemisphere. Now, to help you recover, exercise is good. Edward Taub, who's the University of Alabama in Birmingham, has published a number of studies showing how important exercise is. In 2006, he published a paper involving patients with strokes that impaired the use of one arm and hand. The unaffected hand, for example, if the stroke affected your left hand, then the right arm was put in a sling. Well, patients were forced to use the impaired hand. He's since moved to using basically an oven mitt on the good hand. This procedure is called constraint-induced movement therapy, or sometimes just CI therapy. A control group received cognitive relaxation and physical fitness exercises for the same amount of time. Was there a difference between the groups? You bet there was. Look how much better constraint-induced therapy did. Most during 2 weeks with the 10 days of training and the weeks and months afterwards. Gottman in 2007 summarized research that showed that exercise can improve learning and memory, age-related cognitive decline, and reduce the risk of neurodegenerative diseases. My doctor once had a sign in his office saying that exercise is the answer to everything. There's a certain extent to which he's true. As far as stroke recovery goes, it certainly seems to be true. Exercise also reduces inflammation. This is a little summary of his research. Exercise will block inflammation, neurodegeneration, that is Alzheimer's disease, Parkinson's disease. It will improve cognition, plasticity, neurogenesis. This shows very briefly a critical factor in brain recovery after stroke. This also shows how antidepressants work. And that's one reason why antidepressants will help in the first year of recovery. Antidepressants increase norepinephrine and serotonin, which in turn increase BDNF, that stands for brain-derived neurotrophic factor, which is like miracle grow for the brain, and that helps your neurons. That relieves depression and also helps you recover after a stroke, especially during the first year. And these are suggested readings. Stronger After Stroke. Now it's third edition by Peter Levine. The Brain That Changes Itself by Norman Doidge. This has changes that show all the sorts of things that the brain can do, including a chapter on Edward Taub's work on constraint-induced movement therapy, and then My Stroke of Insight by Jill Bolte Taylor. So that ends my presentation for today, and it didn't last nearly 10 hours, so I think I'm okay.
Hey, doctor, one quick question.
Yes.
How will you get our PhD certificates to us?
Can I give you a PhD?
No, now that we've gone through there, how will you get that certificate to us? Our PhD certificate.
Oh, I wish I could, but only accredited institutions can do that. I got my PhD at Northwestern University, so you have to go someplace like that.
I'll make you up one, Dennis, and send and message it to you.
Yeah,
I have a question.
Yes.
The last couple of days, I've seen several posts on the list about regression. People who are 8 or 9 or 10 years out who have been walking on a treadmill 3 times a week and suddenly they find that their walking is deteriorating, or their hand movement is getting kind of squishy. One person described it as squishy. What can you say about regression and how to avoid it?
Well, regression does typically occur if one stops therapy or stops doing the exercises, unless you have gotten to full recovery. And by full recovery, I mean all the spasticity is completely gone. Unless that happens, you will regress. That is, you'll go backwards through those Boomstrom stages. So the only way to prevent regression is to keep up the exercises, preferably on a daily basis. Otherwise, regression will occur.
Nobody wants to do that.
No,
But
well, that's the key. Nobody wants to hear that, and I don't think that all those folks are doing it. The other thing that I see in these posts, Rebecca, is people seem to have out their magnifying glass, like one day, one bad day or something. They call it regression. I always call it a bad day, and you could actually string a couple of them together. But, well, you've seen my posts. I post a thing about the stock market, and I draw a line through it. You know, the line goes through a bunch of ups and downs. So I wonder if these folks are actually in regression, as Dr. Hetzler would define regression, as opposed to some kind of a temporary setback. But I don't know. All I can do is read the posts like you.
And
stroke recovery is not a straight line. It's
Right.
it's a jagged line, and you have to look at the main angle of the recovery.
Right.
And one nice thing about stroke recovery, now I'm not trying to put any other disease down, but unlike something like Alzheimer's disease or Parkinson's disease or multiple sclerosis, those people will continue to get worse. With stroke recovery, you can improve if you put in the time and the effort. And that's not the case with these other diseases. You will continue to decline.
The one thing you have to do is make sure that you change up your exercise routine a little bit. Keep doing the same thing, the body will kind of plateau, and it'll seem like regression. You have to change up your routines every once in a while to keep your body guessing and keep going.
Thanks for bringing that up, Ken, because I think that's the other part of it. You know, some of these people who talk about regression have said, you know, I've been riding my exercise bike for an hour for, 3 or 5 years or something. And after a couple months, I mean, might get some cardio out of it, but if you're not, like you're saying, if you don't challenge your brain and mix it up, then you're not like maximizing your neuroplasticity.
Right, your brain responds to challenge.
Right.
I think William Lowell has described this very well in the neuroplasticity workshop that he gave, where he described it as you're moving upward on the scale, and then suddenly it'll even out a little bit, at which point you know that you have to change up your exercise routine in order to continue getting benefits.
Yeah, we did that twice. We did it once in Roadmap number 11, and we did it in Stroke Buddies number 23, I think. That concept. And you also, when you start plateauing, that line goes flat, you better get on changing those exercises before you get released from physical therapy, because a lot of physical therapists don't change up your exercises, and therefore, in a sense, they plateau you because you don't know any better. So if you know this, pardon?
you go to a physical therapist and they will ask you what kind of exercises have you been doing. Okay, those are fine. Keep on doing those exercises rather than giving you new exercises.
Right. Yeah, I've seen that some, and I guess I'm kind of saying that in a sense that they plateau you, and if you have this knowledge about mixing things up, you can keep that from happening and keep yourself from getting released from the therapists have some latitude here with the insurance company. It's not like some people get a certain number of sessions, but um, they're they decide whether or not you're plateauing or not. That's one reason that I preach the whole thing about having a different relationship with them. And this is an important aspect, I think, to understand. If you understand this concept, you can go to them and say, "Hey, I'm worried about. I love it here. I'm worried about plateauing. What can we do to mix it up so that I can keep making progress and I don't get graduated or released or shown the door?"
I have a question, Bruce, about diet in the brain. It seems to be a lot of conflicting opinions about what is best, the best type of diet for your brain. High fat, low fat.
Well, I'm not sure what the most recent research shows, but a healthy diet is good, like the Mediterranean diet.
I didn't catch her name, but it's SB Flanders.
Sandy, I'm Sandy.
Um, Next week, and we haven't fully researched it yet, but next week, Sherry Morant, who's an occupational therapist, personal trainer, she's not a nutritionist, but she has a wellness page, and she does monthly meal planning and stuff like that. And we're going to take on the subject. Originally, I was going to call it dispelling diet myths, but I don't want to be negative with that. We're going to talk about all the different diets. Sherry and I both believe that we are both on I have a diet. I'm not on a diet. I have my own diet. So we're calling this segment the best diet for you and post-stroke. And I'm going to do some research into if there's any scientific evidence about what types of foods help. A lot of people seem to think, fish has always been called brain food. People tell you take CoQ10 and fish oil supplements and things. I don't think we're going to get into supplements because that's at least 2 cans of worms. And but basically, we're going to cover all an overview of the different diets and talk to you about how to put together a lifestyle change of plans so that you build your own diet. You're not like going on a diet because there's no one thing. It's the only thing that's one size fits all is those stupid Johnnies they give you in the hospital. The rest of life and the rest of recovery and things like diet are really, personalized. What if you can't eat fish? What do you do then? What if you hate fish? So are we going to answer everything in an hour? No, but we're going to go over and give some, good basic information. So if you can't join us next Tuesday, then it'll be on YouTube on Wednesday, I hope. I try and get these up by the next day.
Right.
There are foods that are, oh, go ahead.
What was that, Rebecca?
I was going to say there are foods and nutrients that are superior. Fruits and vegetables, whole grains, lentils, beans,
Protein.
those foods are superior even to fish. I have a lot to say about diet, so I'll be at that meeting.
Okay. You'd be welcome to join us as a co-host if you want, or you can just be an active participant.
Yeah.
For those of you who don't know, Rebecca, she does a lot of research, so I would love if you got any links or anything, Rebecca, that you send them to me because Well, I'm not behind the 8 ball yet, but because I got a week to figure this out. And I'm not going to become a diet expert in a week. What I'm going to do is learn enough to facilitate the conversation. Sherry and you and a number of other people know about it. And the other thing is basically what we're going to do is promote in this diet for you concept, you know, healthy eating, plant-based. What you're talking about is protein. Fish is protein. As an aging vegetarian, I'm eating red lentil pasta and lots of fish and shrimp and things like that, black beans, goat cheese. There's lots of things with protein in them, and protein seems to be important for a lot of things. But the main thing is people go on diets, and whether they're trying to lose weight or be healthy, diets don't ever seem to work because you go on one, and the fact that you go on one means that you think maybe you can get off of one at some point, and I think that's the wrong thinking. The people that I see lose weight or the people that I see become healthy basically change their lifestyle. And, so that's the kind of thing. And healthy foods, plant-based, shop the outside of the supermarket. Don't eat anything your grandmother wouldn't serve you. Don't eat anything you can't pronounce. Those kinds of things are a lot of it's common sense and just practical information. So that's what we're going to try and package up because this seems to be a big issue in the groups, as you know from monitoring them, and as our the it's been noted that a lot of people are concerned about diet, and all the diet posts I see, somebody will come on and go, "Oh, you got to do keto, you got to do paleo." They all are like touting whatever they're on, and I don't think any one is the solution for everybody. And I think that it's kind of like, ooh boy, I don't know if I could go there. I was going to say it's kind of like religion. You can take different parts from different philosophies and put your own philosophy together, but I sure don't want to stir up the religion pot. So that's what we're going to promote, and I would welcome you in that discussion. It's likely to not break down, but turn into a discussion fairly quickly because all the presenting we're going to do is about the existing diets and the concept of changing your lifestyle. So it'll be a lot of Q&A in that one, I think. We'll see.
Right.
I got a week. To pull it off. Anybody else?
No, I want to thank the doctor. Thank you, Bruce, for sharing your insight.
It's my pleasure. I always enjoy talking to this group.
Well, we enjoy having you, and like I said in the beginning, I find your presentations not only useful but fairly easy to understand. I learned a number of things. I wouldn't have told you I'm a brain scientist, but I wouldn't have told you I'd learned as many things as I did today. Let's see. I got an interesting question.
Sure.
Has anybody done any study? Why do you think brains are contralateral or backwards? Does neuroscience ever address that basic fundamental question? I mean, what's up with this eyes crossing and this side controls that side? Is there some scientific reason for that? It seems like it'd be a lot more logical to, have it be same-sided, ipsilateral.
Not that I'm aware of.
Okay.
And I think I mentioned, maybe it was in another presentation, but our oldest sensory systems are taste and smell. And those are ipsilateral. That is, information from the right side of your tongue goes to the right side of your brain. And information that goes up your right nostril that you smell goes to the right hemisphere of the brain. All the other senses are newer, and they are contralateral. But here, I haven't really talked about this because it's not really relevant, but pain, interestingly, is bilateral. That is, you feel pain on both sides of your brain, both sides of your brain.
Wow.
Pain wants to get through.
Who was it? Marcel Proust once said, "Pain is the only master that we serve."
Mm.
Anyway, not to get literary on everybody. Well, that's real interesting because you would think if it almost as if well, it sounds like evolution played a serious role here because some of the early things were ipsilateral and then developed into contralateral. I'm real interested in the whole ipsilateral thing because I figured out how to do bilateral patterning, and I've kind of fooled around with ipsilateral. I think I'm a big believer in using whatever parts of your brain are left or you can to help and train the other side. So ipsilateral patterning is one of those things that's on my radar screen. Oh yeah, one other thing, fatigue. It sounds like a lot of fatigue is caused by what I call running out of brain. We keep using our brain for all kinds of other stuff, and things like fear and things like this take up part of our brain. And it sounded to me like that was possibly contributing to the whole fatigue thing.
Well, it could contribute to it, but again, people have fear and anxiety without having a stroke.
Well, not just fear and anxiety, like, you're walking around using other parts of your brain to, walk. It. I know that I've said to people who haven't had a stroke that they don't really understand. Like when I walk up the beach with them, it could be March or something, and I'm all sweaty and they're not, and it's like it's not that I'm worn out aerobically or physically. It's that it takes me about 3 times. I've always said 3 times the amount of brain that it takes the person I'm walking with to walk up the beach and back. So if that's the case, then that's going to contribute, somewhat to fatigue because we're always taxing ourselves in a lot of, everyday tasks and life. Just
Correct.
Yes.
just observance of mine. And one more, can left side neglect can occur in somebody that has a left stroke, but it's more
Oh, no. Well,
more prevalent in the right?
left side meaning left side of your body
Right.
neglect occurs following damage to the right hemisphere. But
Can you have left side neglect if you have a stroke in your left hemisphere, I guess is the
if
question.
you have a stroke in your left parietal lobe, you typically do not get right side neglect.
Can you get left side neglect? Or is it strictly if you have a right side stroke?
Strictly if you have a right side stroke.
Strictly, okay.
Yes.
I wasn't sure if it was like, from your presentation, I got the impression that that was where it usually occurred. I didn't know.
I'm not aware of any cases of
Yeah,
right side neglect following left hemisphere problem.
I had it, but I didn't have it bad. I mean, I worked with a guy who would eat half of his plate. I mean, I literally watch him and then would go, Stephen, turn your plate around. And he would. I had it somewhat in that I just didn't pay attention over here. So if people approached me over there, the only thing they said in the rehab hospital was make sure everybody approaches you that way and force yourself to look. And that's all I ever did, and it kind of went away on its own. I don't know if there are any techniques for getting rid of it or not.
Well, the only real technique is trying to get you to use your eyes to scan that part of the environment. But the left side neglect usually does go away on its own. I'm not sure how long on the average it takes, but mine did go away certainly within a year, but I don't know how long it took to go away.
Yeah, me either. Mine was definitely gone in a year. It may have been gone in 3 or 4 or 5 months. It's funny. If I could go back, I would like start a journal and write all this stuff down because now, years later, like you're nodding your head, yeah, like you said, well, it was certainly gone by a year. We didn't pay attention to, didn't know to pay attention to things like this. I didn't know I'd be trying to help stroke survivors and it'd be useful to, be able to pull out my journal. I never videotape myself. I have to try and remember what I did and what it looked like when I make my videos. And when I do, the one thing I always do is I jump in at a higher level than I know was involved in my recovery and with other people, because I get like comments, well, I can't do that yet. Well, just do the best you can. And I'm a big believer, by the way, in exercise, exercise, exercise. I had a neurologist come up to me after a motivational speech I gave at Tri-State Stroke Network, and he said that more exercise equals less depression. And I said, it was the first time I'd heard that, about 11 years ago. And he said it was, they'd done a study, a neurological study, and it had proven to be true. So that's one reason I preach get moving and stay moving. It's the one thing you can do. And it doesn't mean you're going to jump out of your wheelchair or anything. You can still do leg lifts. You can still do core stuff, long lever, short lever. Moving does things to your brain. I mean, it's been known in the sports world and the neurological world, and it needs to be preached in the stroke recovery world. So, well, we've kept you and everybody for quite a while. If anybody's got any more questions, we'd be glad to take one or two more. If not, maybe I'll end this. Anybody out there? I hear nothing. So I guess, Dr. Hetzler, I'd like to thank you again and for being willing to share your knowledge with us.